We're going to be talking about drapes and gowns next, reusables and disposables. But really the mission here is that this is introducing the evidence base for reusable and disposable culture. It's introducing the behavioural change, the clinical sides of it, the carbon and the cost. So I've got a really good panel here. Can we do some introductions? Simon first.
Anil, thank you. I'm head of shopping for Birmingham Integrated Care System. So, no, my role is Managing Director of Procurement and Supply Chain for all of the Birmingham Solihull Integrated Care System.
Virginia, we've heard from.
I'm Virginia Ledder, PhD Fellow.
Divya.
Hi, I'm Divya. I am the Senior Trials Manager at University of Birmingham and the main point of contact for Dragon.
Hi, I'm Tom Dawson. I'm a Fellow in Circular Health Economics at the University of Exeter and the founder of Revolution Zero.
To start, but we'll go into more detail on these things, but Divya's going to give us an overview of the Dragon trial first, followed by Virginia. So over to Divya first.
Slides, please. Okay, so Dragon is a multi-center non-inferiority cluster randomized trial which is going to test disposable versus reusable drapes and gowns for green operating theatres. That's the title of the trial. Next slide, please. So I'm going to take you through the objectives of the trial. Number one being, if there's a difference in the surgical site infection rates between single-use versus disposable drapes and gowns. Number two, which is the most cost-effective and sustainable option. And number three, that we will have the data to report the world's first integrated paper which will include clinical, cost, and carbon outcomes. Next slide, please. So this is the overview of the trial. It's a cluster randomized trial, so we are not going to randomize on a patient level, but on a hospital level. The inclusion criteria is any surgery which is clean, contaminated, or dirty, with an incision length of greater than equal to 5 centimeters in adults and greater than equal to 3 centimeters in children. We are going to recruit almost 27,000 patients from 134 hospitals, which are also called clusters. The intervention is reusable drapes and gowns, and the comparator is obviously the disposable drapes and gowns. So the key outcomes are going to be the clinical, cost, and carbon footprint. We are also going to have the process evaluation study, health economics, and carbon modeling within the trial. So all of the GSU countries are going to participate in this trial, including United Kingdom. We have a target of, as I said, 27,000 patients from 134 hospitals, and the target is to recruit 200 consecutive patients, eligible patients, per hospital. So this is the current status of the trial. We have already started recruiting in Mexico. One site is active and 3 more have been randomized. We have 7 countries, low and middle income countries, which are participating in this trial, and we have received ethics approvals from all these countries. Some of them do need FDA, local FDA approvals, so they are outstanding, but then most of them they do not need. The drapes and gowns could either be procured locally or via University of Birmingham. And we have conducted SIVs for 4 countries already. For UK, we have conducted SIV for University of Birmingham, 3 hospitals from that fall under UHB. We're just awaiting the confirmation of capacity and capability. So for UK sites, the key points to consider are whether your hospital is covered by the NHS REC, which is the Research Ethics Committee. Does your hospital have access to both disposable and reusable drapes and gowns, including sterilization facilities, and your research staff capacity? I would also like to add that the surgeon or the anesthetist should be fully engaged. So if you're interested, please use this QR code and get in touch with us. And we can, also there's a link to complete this short survey. So that's it from me.
Hello again. So I'll be here to talk to you about implementation of drapes and gowns in hospitals, and this is part of my PhD. So why do we need to talk about implementation? Well, we've heard everything about the Dragon trial from Divya, and 6 months from now, we might need to ask ourselves, what support do hospital need to actually use the randomized allocation for the hospital that have joined Dragon? And 3 years from now, we might not, the question that might come up is, how can hospital implement Dragon recommended practices? So what can we do to help to make those recommendations happen within practice? And this is why we need to look at implementation. So when we talk about implementing drapes and gowns, we don't just mean bringing a different type of drape and gown within the hospital. As we can see here, and this is a graphic I borrowed from the Implementation Science Consolidated Framework of Implementation Research, there is also other factors that can influence the uptake of drapes and gowns within a hospital. So we're looking at the individuals within that institution, the external environment that surrounds the hospital, so factors that, for example, can include local guidelines or funding, governmental funding. We also need to be looking at what strategies are employed to bring these drapes and gowns within the hospital. And when we think about the drape and gown, we can't just think about the physical drape or the physical gown, but we also need to think of all those processes that are necessary for the safe and effective use of the drapes and gowns. So for example, in the case of reusables, that would be the laundering and sterilization processes. And in case of disposables, that would be the waste disposal process. So we know that there are factors influencing the uptake of drapes and gowns at each of these levels. And this is really what we're trying to find out. So how are we learning about these factors? There's through several pathways. So the first thing is that we've had a look at the literature, we've had a look at the marketing manuals from sterilization and procurement companies. We also learned a lot from setting up the Dragon trial. Divya talked about the steps and where we are now currently with recruitment, but there were several steps that got us there, and we learn from each one of those steps. We also are conducting interviews and focus groups with non-clinical teams that are in charge of using and procuring the drapes and gowns within hospitals, as well as industry members. So we're learning from all of these sources. And overall, we think that at present there are really two main pathways to provide drapes and gowns to the hospitals. So we can go through the single-use pathway, where drapes and gowns are manufactured, they're transported, then they're used and they're stored and used within the hospitals, and then they're disposed and then processed. And then we have the reusable pathway. So we have the manufacturing, the transport again, and then the storage and use. However, then we have also the reprocessing, so the laundering and sterilization. And that cycle of storing and using and reprocessing can be done either within the hospital or outside. And it lasts for about 75 cycles, because that's the average life of a reusable gown. And then after that, there will be disposal of these as well. So again, in these systems of provision, there will be factors influencing how well the hospitals can implement the type of drape and gown that they've chosen. So why do we need to know about this? Because this is our plan. So we know that the Dragon trial is going to provide some results, is going to provide some recommendation on what hospitals should use based on clinical safety, cost outcomes, and carbon outcomes. But then we have this knowledge that we gained through the interviews and through the setting up of the Dragon trial. And through this, we will develop an implementation toolkit that is going to support the hospitals implement whatever recommendation Dragon supports. So this is how we want to bring that evidence that we generated into clinical practice. And then hopefully that means that we can deliver safe, cost-effective surgery while also improving the environmental sustainability of operating theatres and fostering an eco-conscious staff within hospitals and the local communities. So I'm looking forward to this discussion. Thank you very much.
I'll come to you first. Thank you both very much. Simon, I'm going to start with you. So what is an ICS and how do you decide what to buy?
It's a very good question. As an ICS, we have a very mixed economy. That mixed economy is due to many factors. One is education, trying to roll that out, but I believe Virginia's already pointed out on it. The real key one for us is infrastructure, having the sterilisation and the interdependencies of the wider circular economy to ensure that we can actually deliver this. You know, we've got a laundry service who are up to capacity, and we have difficulty just getting our general laundry delivered. You know, holding up surgery in the current recovery stage that we're at is, well, it's not acceptable. So we need to build the infrastructure to ensure that we can utilise more reusable, and I'm talking reusable as the wider piece, never mind drapes and gowns, to actually deliver more of an impact across our service. And I think also one of the queries I would, and we've had NHSE colleagues here today as well, is model hospital and girth, all those that measure us and tell us about the best practice. We need for them to start including the best practice of greener approach and sustainability. So we're not talking about just bottom line costs, we're actually talking about the whole life cycle and costs as a whole. So we are moving on it as infrastructure gets better, and that's down to me to work with the marketplace to create that. Then, and hopefully we might be hearing more about that anyway, we will be doing more, but the facts and data prove it's something we should be doing. We just need to ensure we've got an infrastructure to be able to implement it.
Good, thank you. Let me follow up with you. So I'm a surgeon working in one hospital, which I think is within your ICS. So how many hospitals are in the ICS?
So there's 5 hospitals in our ICS.
So as an individual clinician, do you think either now or in the future, will I have any voice in the purchasing and decisions at that level? And don't tell me what I want to hear, tell me the truth. And if I don't, how can I begin to generate that voice?
Yeah, and apologies. We have 5 trusts. We have a wider range of hospitals, and you can get into its hundreds if we start talking about community places. We have 5 NHS trusts that have a fragmented approach. Now, sitting right in the middle of the audience there is one of my clinical nurse specialists. So procurement has changed and adapted a new approach. And most procurement now have clinical nurse specialists to support us with the rollout and the education and that cross-functional decision-making across not just the PPE, but all factors of what we're doing. So they're an integral part of all the procurement processes that we do. They always have been, and they're going forward, as I say, I have my clinical nurse specialists, because one, I can be baffled with BS through some clinicians who tell me this is the way it is, but my clinical nurse specialists go, what the hell are you talking about? That's not the case. So I've brought in those practical professionals to help us to actually align. And more importantly, and I think this is critical in the way we're moving forward now, is I know there'll be scepticism if I come to see you, because you'll be like, Simon's only after the bottom line price. He's trying to get the cheapest. He's trying to mug me off. Well, actually now we're showing that it is true value, including our greener approach as well.
Good, so hopefully our results will line up to that, because our first paper will publish clinical cost and carbon. So
absolutely, that's excellent.
Tom, over to you. I wonder if you could tell us a little bit more about what you do, how you're trying to change things. And I guess the question to link it back is, we're going to have the results from this trial relatively soon. How can we link the gap between what we've just been talking about there?
No, it's really good. So the whole area of reuse, or if you think about taking any item and washing it multiple times, it's been going on for thousands of years. But we're not talking about a top. We're talking about something that has to be in a very controlled environment, has to hit all the regulatory things. So our focus has been doing things more effectively. So how can we not just think about how we're going to replace single use, but how can we make it even better? How can we add the features? If you're going to invest the money and the resource and the product, make it the best product you possibly can for reuse. So more effective and then more efficient. So you've got the products more effectively and more efficiently turning around, the materials, the energy, reuse of the energy, reuse of the water, and actually reuse of information, which is really important. And one of the things, again, a lot of bad stuff happened with the pandemic. We can remember that, but a lot of good stuff. So now there's technologies where we can produce the infrastructure off-site in around 3 months and install it. And we did this in Cornwall. So we started the build in January. We had it installed in the ground at the end of March, fully validated at the end of April, and then delivering in theatres once we trained the staff in June. So this can be done. So there's a rosy future ahead of us.
Let me follow up with you. There are a range of single-use equipment, PP and beyond, in an operating theatre. And I don't think we can do, Divya, can we do a randomised trial on every single piece of advice or every single piece of equipment in an operating theatre? I don't think so. I think they're too, sorry, it's a trick question. I think they're too expensive, they take too long. So from this trial, which is what the surgeons perceive as one of the highest risk things that we wear, because it's in such direct contact with the patient, are there other areas in the operating theatre and beyond where this can apply? I'm thinking of like the red slide sheets. Does everyone know what a red slide sheet is, or should I explain that? Who's still using a red slide sheet in their practice? It's quite a lot of people. Who has managed to change that red slide sheet to a non-red slide sheet? Has anyone managed that yet?
No.
So can we start applying that evidence beyond drapes and gowns?
Well, sadly not, because we've got red reusable slide sheets. But no, joking aside, our red reusable slide sheets, it makes obvious sense. You're taking something that's high risk. We're doing the studies, and it's very logical. There's a poster here showing warm-up jackets for the operating rooms as well. Really good work done with UCLH. We've shown that, and we talk about hats. We still want to do the post-market sort of research to make sure we're continuing to improve and do things, but we can build off these sort of large studies. I mean, almost 27,000, that's a big number. It's a big number.
That'll be one of the world's biggest. And Virginia, same for you. So in the carbon models and interviews you've done, do you think, is it worth doing those for sort of single-use and reusable hats and stuff, or do you think, so are carbon models hard, and should we apply the knowledge or should we repeat?
I think what we're hoping to do for the carbon model is develop a methodology that is transferable, so we don't have to go again through the process, because again, we want to keep it fast and pragmatic. And so I think what we're aiming to develop is a methodology that is transferable across different types of PPE. And so definitely I think that the learning should be applied across different other types.
And Simon, let me come back. I'll push a bit harder now. The cheetah trial, which we did and published a couple of years ago, so that's changing gloves and instruments. We've got clinical, cost and carbon now, but we're still trying to push that into everyday practice. So one of the risks is that we do this trial, we publish it, it shows a finding, but then we're left with this gap. And you mentioned groups like GIRFT. Does everyone know what GIRFT is? Get it right first time, NHS England. How can we push harder now to close that 2 to 3 year gap after this trial happens? Because hearing from Hugh and others this morning, we don't have the time to burn on this.
No, Hugh's absolutely right. I mean, last year I left here completely daunted by Hugh's presentation. But he's absolutely right. We've missed the boat already. We need to just start actually reacting and behaving far different. I've been part of the Design for Life team, the DH team, to look at all medtech devices to be reusable, recycling, remanufacture. And, that's where we need to be. I think as this group, and today we've had the greener team from NHS England, we have to be around that table. We've got to be supporting to make those new decisions. And more importantly, as the NHS and with our NHSE colleagues, we've got to be sharing best practice and actually challenging why aren't they being implemented. That's where we need to make that difference going forward. And I have a little challenge, Virginia, if that's okay.
Go for it.
So Virginia, as part of being that team, one of the things you looked at on the reusable piece was straight to waste and disposing.
Yeah.
I think what we need to be doing is challenging our reusable drapes as actually before that final waste is recycling, remanufacturing options, and that needs to come in as that next piece. That's where we need to be pushing, because it is material, and why can't it, after it's been cleaned, turn into rags for our cleaners or something like that, you know? So I think there's more to do with that potential recycle, remanufacture. I know we can't reuse, because it's got to its purpose, but yeah, apologies.
No, so I think Dragon, I'm hoping, is the seed that will grow a lot more change, and we're learning how we can take the investment and infrastructure from Dragon Trial, which has come from the UK taxpayer, and grow more. So that's an area. And Tom, back to you. So there's a question here about the pros and cons of outsourcing and laundering and sterilisation. From a range of hospitals, from very well-resourced to very small, you know, if I've got an interest in this and I work in one of those hospitals, how can I begin to take change back to my site? Can I, if I've only got disposable drapes and gowns, is there any point in me having that conversation with our teams in that hospital? If I only have reusable, should I have the conversation about why we keep running out and stuff? How do I take that back?
Well, I think, actually, I think there's more of a risk of running out with a single use, really. We look at global supply chains and, you know, all the nasty things that are happening in the world at the moment. I think we're all fairly nervous. But I think the good point is the ICS, and there's a power of the ICS, is even if you are in a small trust or a small hospital, it's definitely worth having those conversations. And it's about one of the first two things that we look at doing is the stakeholder mapping. Who's in the room? Who makes the decisions? Who's the dementor? Now, forgive me, NHS, but you've got lots of dementors in your organisations. You want to address them, the people who suck the living joy out of your innovation, your sustainability. You all know who I'm speaking about. You'll know, but you want to address those head on. And actually, this stuff is so important. It's negligent not to do it. If you're delivering better healthcare, it's more sustainable, and it's saving money. If you're a dementor, you should be waking up at 2 a.m. in the morning worried about your negligence that you're causing the system. And that has to be made very, very clearly. But map out the stakeholders, map out the procurement, how you procure it, and then work with the people to make it happen.
So I've got a challenge for the audience as well, and yourselves. And tying into, I've heard green surgery checklist. I've heard this morning that you know, the clinician will have an increasing voice in what is reused within the operating theatre. But also, I exist in an environment where I see a lot of single-use equipment coming in, more and more, especially around some of my practice in things like minimally invasive surgery, for example. So can we put together the views of the people in the room, the expertise here, what's been established in the green surgery checklist, and reprioritise what the next year or two could look like in terms of what is the list of equipment that is currently single use that we can look as a community to be switching back to reusable? And, you know, because I think there are a lot of unknowns in the individual still. So when the drape and gown's going to be thrown out, the reusable, how can we reintroduce that into the recircular economy? The individual surgical device, the bigger surgical device. So I think that could be a takeaway from today. We can reprioritise a list for the future, a living list of single-use equipment that can be either changed or reintroduced into a circular economy. So Tom first, is that worth doing? Do we know that already? Are there lots of unknown unknowns?
There's unknown unknowns, but there's many known knowns. So we can actually work with those and actually work with them. Prefer to take a very positive, okay, we can do this now, we can change this now. So that's something we can definitely do. Definitely an implementation toolkit is useful. You mentioned get it right first time. And I think one of the arguments against reusables, I can't have my special drape that's 2 centimetres here and 5 centimetres here and that. And people need to get over it. It needs to be a standard drape sets. Standard, and we're starting to do work for there and working with the Royal Colleges. I think we'll get into good place, but implementation toolkits and standards are definitely the way forwards.
Simon, there's a good question for you there. How do you persuade hospitals to change when the financial and carbon changes are seen further down the line? They're seen in the community, they're not seen in the hospital.
I think this is about actually sharing that message, and there is going to be a place in time where we're going to have to speak to the community, where our healthcare is free of point of entry, that actually some things we're going to have to do different, and are they supportive of this? So apart from cross-functional dialogue with our clinical and health colleagues, that needs to include communities and the community group as we move forward, so they take acceptance and understand the difficulties we have and understand the things we're doing. So I think it is a must, it is the way we need to go, but we need to bring them on our journey with us. You know, and also, you know, looking at the new procurement rules, social value and sustainability is in the same bucket. You know, and that sustainability and social value has a massive impact on each one. And that's where we need to learn and bring them together.
And then I'm going to finish with you, Divya. So if I'm a surgeon or an anaesthetist in the audience and I've forgotten everything you've just said to me about opening a trial and the list of things you've given me, and it's just left my brain, which I know that's uncommon, but it happens. Can I come and find you at lunchtime?
Sure, yeah.
Is it appropriate to get your email and say, can you send me a list of instructions?
Absolutely, yeah.
Because I think that tends to be how we run our trials. And the final comment, is Dragon what we would call efficient, or is it inefficient? How have we designed it to be fast?
It's definitely efficient in the sense that the best thing is you don't have to take a patient-level consent. So it's going to be randomized on hospital level. You just have to capture data from the follow-up records, from the records of the patient. So that's going to be like very efficient. Less time of research staff. So definitely.
I'd like to thank the panel very much. Thank you very much.